All right, we're right on the hour. Thank you everyone for joining. So hello and welcome everyone to today's HIV listening session, Harvesting Hope, Strengthening HIV Services in Urban Indian Communities. We are pleased you could join us, and we kindly ask that you place your name, organization, tribal affiliation, and title into the chat box. My name is Divya Nanduri, and I'm a Technical Assistance Manager here at NCUIH. And joining me from the NCUIH team are Dr. Kimberly Fowler, Vice President of TART, Kayla Emmerich, Public Health Associate, Margot Bailowitz, Public Health Project Assistant, and Rachel Dio, Communications Associate. If you have any technical difficulty during today's session, please send a private message to one of our team members and they will assist you. In addition, we welcome any feedback you would like to provide about your listening session experience in our survey, which is also going to be posted in our chat box, or by using your phone to scan the QR codes that are going to be showing up on the corners of each slide. Next slide, please. So before we begin, we would like to bring your attention to a brief disclaimer that this event is made possible by the Minority HIV/AIDS Fund through the Indian Health Service. Next slide, please. And for those of you that are unfamiliar with NCUIH, here's a little background. The National Council of Urban Indian Health, also known as NCUIH, is a national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas. NCUIH is the only national representative of the 41 Title V Urban Indian Organizations, or UIOs, under the Indian Health Service in the Indian Healthcare Improvement Act. NCUIH strives to improve the health of over 70% of the AIAM population that lives in urban areas, supported by quality, accessible healthcare centers. Next slide, please. I would like to go over a couple of housekeeping items, which include the following: that the session is being recorded. All mics have been muted unless otherwise directed. Please turn your camera on to allow for optimal interaction, and questions can be asked during the session via chat or coming off mute. And as always, the evaluation link is there on the QR code at the bottom corner of the slide, or the website link that has been posted in the chat. Next slide, please. So here's today's agenda. And as shown, we will begin with the opening remarks from our Vice President of TARC, some updates from IHS, and then move into a 35-minute open floor listening session. And we will promptly end the session at 3 p.m. Eastern Standard Time. Next slide, please. And I think we have Dr. Kimberly Fowler in the room today, so I will turn the floor over to her for opening remarks. Dr. Fowler?
Yes, good afternoon, good morning to some, my apologies. I just wanted to welcome everyone to this event. It's going to be a great opportunity for all of our UIOs to share on their needs and gaps and understandings around what's happening in their communities around HIV and AIDS and the work towards ending the epidemic. And so we're really excited that you could join us today. And I just welcome you to this listening session that is really going to be informative in helping to share that information with IHS. So with that, I will turn it back over to Divya.
Thank you so much, Dr. Fowler. And now I would like to introduce our IHS National HIV/AIDS Program presenter, Rick Haverkate. Next slide, please. All right, Rick is an enrolled member of the Sault Ste. Marie tribe of Chippewa Indians. In 1993, he earned an MPH from the University of Hawaii. His 32-year public health career has been focused entirely on Indigenous peoples of North America. Rick has assumed various roles, including community health educator, public health advisor, and director of public health at the tribal, state, and national levels. He has specialized in the operational management of HIV/AIDS, maternal and child health, tobacco health promotion / disease prevention, and community capacity building, lots of things. Rick currently works for the Indian Health Service as their National HIV/AIDS Program Director. And I would like to turn the floor over to Rick with a big welcome.
Well, thank you very much. It's such an honor to be here, and thanks for thinking of IHS and your work towards informing your communities more about what's happening around the country, specifically with Indian country and HIV. I'm going to talk mostly about HIV today, but I want folks to know that we always talk about it as a syndemic. So there's HIV, hepatitis C, and sexually transmitted infections, commonly known as STIs, and the number one we're worried about currently is syphilis. You may have heard some of the horrendous rises in syphilis rates among American Indian and Alaska Native people. So while I'll be talking about HIV today, I'd love to come back and speak with you in the future about STIs, specifically syphilis. So This short presentation is going to provide you an HIV data update for American Indian and Alaska Natives in the United States. So I based this brief update on what we have as the latest available HIV statistics for American Indian and Alaska Natives. And I'm using data from the Centers for Disease Control and Prevention reported through December 2022. But a little word of caution as I begin. As shown in multiple studies and due to missing or misclassified racial data on various health conditions, national disease surveillance data probably undercounts American Indian and Alaska Native people. Not a surprise, right? The IHS Division of Epidemiology and the CDC are constantly updating HIV data using more recent internal IHS data. HIV, you may know, is a reportable disease, and as such, part of the CDC's National Notifiable Disease Surveillance System takes into account all those states, municipalities, including IHS, that report HIV up through the systems. And like all health system providers, the IHS facilities report notifiable diseases to their respective state health authorities, which then transmit the data to CDC. So we get a lot of questions on what is IHS saying about the data? And I think the easiest and best, most accurate, most up-to-date way is to go to the CDC for those data reports. And we'll talk about where I get that data in a minute. But the CDC publishes the HIV surveillance report annually, and you can link to that report from a link I'm going to drop in. It's on this. If you go back one slide, please, just one slide, and then I'm going to see how quick and easy I can stick something in the chat. So I'm going to stick this link in the chat, and that will take you to the latest CDC surveillance updates. All right, next slide. So between 2017 and 2020, there was a steady rise in the estimated number of new HIV infections among AIN people. And that included all ages, both sex, and all transmission categories. We were the only ethnic group in the US that experienced an increase in the rates of new HIV diagnoses. Everyone else, thankfully, is seeing a drop. We don't know exactly why that is, but we're working on that. Some of them might be, we're doing a really good job in testing. A lot of your urban Indian organizations and a lot of our tribes and IHS facilities are doing a really good job testing and getting people screened for HIV and getting them to know their status. So it might be that because we're doing such a good job, we're capturing even more numbers. So it looks like our rates went up. That could be a good thing, meaning that more people are getting into care. It could also mean we are actually seeing more new infections. But the estimated number increased from 190 people in 2017 to 230 in 2020, representing a 21% increase. We do see a decline in the estimated HIV incidence in 2021. That was a hopeful sign, but we need to continue monitoring this to see if it continues to be the case. We do see that we're reaching those living with HIV who are undiagnosed through innovative strategies to increase screening and testing and to reduce HIV stigma. So we're working really hard to make sure that we get people to know their status, get them in for screening and testing. And then we're also, I think a big part of that is we need to really work hard, continue to work hard on reducing the stigma around HIV. So the next graph looks at the most recently available data for AIAN in 2021. The data comes from the individual states which report their diagnosis of HIV to the CDC. Once the states transmit their HIV data, the CDC's National Center for HIV/AIDS, Viral Hepatitis, STD, and TB prevention then collects, cleans, and analyzes the data and makes it available to the general public. And that was in that link that I sent in the chat box. So the figure on the screen shows trends of new HIV diagnoses by race and ethnicity. And this graph you see is not fully inclusive of all races in the US. For this slide, I've zoomed into a smaller chart of racial groups with lower rates of new diagnoses. And that explains why it might appear a bit grainy and does not include all racial and ethnic groups in the US. But as you can see, the rate of new HIV diagnoses among AIAN increased in 2020 and again in 2021. And that increase in 2021 may reflect those who were not tested and diagnosed in 2020 because of the impact of the COVID-19 pandemic. But according to this data, the rate of HIV for our natives is approximately twice that of their white counterparts. So I do think that's cause for concern and definitely cause for action. In 2020 and 2021, the rate of death for AIN, that's the blue line in the chart, exceeded that of their white counterparts, which is denoted by the green line. It had previously been lower than the rate for their white counterparts. We were pretty excited last year and the year before as we saw a decline in the death rates for our Native folks, but we've seen an increase. So next, we're going to look here at the HIV transmission mechanisms among AIAN people in 2021. So the CDC data shows that the majority, or 79% of the reported HIV diagnoses among Native people was among men. Most of the documented HIV transmission among these men was male-to-male sexual contact, which accounted for about 80% of the new diagnoses in that population. The second most common transmission route is male-to-male sexual contact plus injection drug use, and that accounted for about 9% of new diagnoses among men. So among American Indian and Alaska Native women, heterosexual contact at about 63% was the main transmission route, followed by injection drug use at 37%. The number of new HIV diagnoses among AIN women at 46% is the highest it's been since 2017. And other statistics include a recently published CDC report on American Indian and Alaska Native adults in HIV care. So this was a report from Native people, adults who were actually in care for their HIV. And this national monitoring project uses in-person and phone interviews that CDC conducts with persons in care. And the project seeks to understand better and document the experiences and needs of persons in care. The analysis concentrated on patients who self-reported as American Indian or Alaska Native. So it's not an IHS, it's done by the CDC. But these data showed that robust patient adherence levels and some room for improvement on viral suppression, which is really a crucial indicator for both patient health and preventing HIV transmission. So we need to get people into care, keep them there to help them prevent new transmissions. And we call that treatment as prevention. If we treat people who are HIV, living with HIV, get them to an undetectable viral load, they are virtually incapable of transmitting HIV to anybody else, specifically through sexual activity. So isn't that incredibly good news? I mean, I don't know if everyone knows that, but getting people into care, treating them, getting them virally suppressed prevents that person from transmitting HIV to somebody else. So I told you some bad news. That's some really good news, in my opinion. The same report showed that 86% of American Indian and Alaska Native adult patients on antiretroviral therapy were adhering to their care plan. 86% were adhering to their care plan. 64% achieved that sustained viral suppression I talked about. That means we can't really detect HIV in their blood. The amount of HIV circulating in that person's blood system is so low that it's really undetectable. They still have HIV, but we can't detect it in their blood. And in the past 12 months, among these people in the study, in the past 12 months, before the study, 76% of American Indian and Alaska Native adult patients achieved viral suppression as of their most recent test. So that's really good news. 86% were in therapy, adhering to their plan. 64% achieved sustained viral suppression, and 76% of them were still at that viral suppression as of their most recent viral load test. So we're doing better than a lot of communities in the country. So really good stories for those of you working in urban Indian organizations, tribal health, and IHS facilities, getting our people into care or referring them to care. So next slide. And a recent MMWR, that's a report put up by the CDC, and you'll see the link there at the bottom. It's volume 67. That's an easy Google search if you want to do it. But that recent report that used in-person and phone interviews to understand better and document persons' experience and needs in HIV care The CDC showed that the effects of underlying challenges faced by our Native people living with HIV are still really troubling. We know that approximately 50% are affected by poverty, 20% by substance use. And from our healthcare providers throughout Indian country, we hear that substance use disorders pose one of the main barriers to treatment, the treatment adherence, specifically in HIV treatment programs. And substance use disorders are really overrepresented in rural and poor areas. And in Indian country, this is no exception. Also, poverty can create barriers to consistent care, such as lack of transportation or unstable housing. And the well-documented under-resourcing of IHS relative to other national health systems can mean there's a limited access to things like behavioral health or recovery programs. But IHS is making innovations in healthcare and continue to do that during COVID-19 around such things like telehealth. Still, our communities often don't have reliable internet or cell phone data coverage, so that digital divide you might hear about has a more significant impact than ever before on our Native communities. And most troubling is the high proportion of patients who reported stigma. Stigma can have severe effects on treatment-seeking behavior, on mental health, and the ultimate well-being and outcome of our Native people living with HIV. But to reduce stigma, those of us working with Native communities must continue our efforts to promote a better understanding of HIV and the fact that we can treat and effectively manage HIV as a chronic disease. Next. So I want to thank you for listening to this HIV data report, and I encourage you to stay in touch with all the activities we're doing through IHS headquarters. And to get regular updates from the IHS National Program, please consider subscribing to our IHS HIV listserv. For more information, you can go to ihs.gov and just search HIV/AIDS. So ihs.gov and search HIV/AIDS. Please remember to check out cdc.gov for a variety of data and statistics on American Indian and Alaska Natives. And you might also go to hiv.gov to help increase your knowledge about HIV and discover more about access to HIV services for people at risk for or living with HIV. I want to thank you again for your time. Next slide. And I'm happy to stay online, of course, and participate in the listening session, take notes, get back to you immediately or in the future with any comments or answers to your questions. Thanks.
Thank you so much for those wonderful updates, Rick. Divya is having a few technical difficulties at the moment, so I'm just going to step in and transition us over to our listening session open floor. My name is Kayla Emmerich. I'm a member of the NCUIH team here. So as I said, we're opening our listening session open floor here. This is a 35-minute virtual listening session, which provides a unique opportunity for urban Indian health leaders to engage in discussions with the Indian Health Services National HIV/AIDS program to discuss the utilization of new and upcoming funding addressing HIV, HCV, and STIs for American Indians and Alaska Natives living in urban settings. Historically, federal resources have enabled UIOs, as well as the remainder of the ITU system, to embark on a path of success in terms of eliminating HIV in Indian country. To assist this discussion, I wanted to introduce the topics included in this session. Those include addressing racial misclassifications in data collection, as Rick mentioned, support of traditional healing practices in HIV prevention and treatment, effects of COVID-19 on data collection and testing services, youth and family funding services, and appropriations and budgets regarding HIV prevention and provision of services. I'm just going to go ahead and drop that little list of topics in the chat as reference, and our open floor is now open. We would love to hear from you.
And this is Kimberly. If you do have any comments or questions to ask, feel free to come off mute and just share those. You can also raise your hand so that we could create some type of queue, or feel free to place them into the chat as well.
Yes, as Dr. Fowler mentioned, yeah, feel free to use the chat feature. Any and all thoughts here are welcome. Yeah, any questions or challenges that you've faced, this is what we're here for today. So the floor is absolutely yours. We're open to any comments from anyone here. Oh, Candace, I see your hand.
Yeah, thank you, Kayla. This is Candace Colleen from NCUIH. I just had a question for Rick, and I was curious if you could offer any insight into how UIOs can better collaborate with IHS to address a number of the issues he raised in his presentation, specifically among the urban Native communities that they serve.
Hey, good question. We're always looking for a collaboration. I'm so glad to hear you're interested in doing that. Come right to me. Maybe we should facilitate a follow-up to this meeting with NCUIH and IHS. I think NCUIH is the logical go-to, but we do work directly with some of our UIOs, including the Seattle Indian Health Board, NARA out of Portland, Oklahoma City Indian Clinic, and a few others. So we're always looking for ways to collaborate. I would love to see us maybe have a national meeting in the coming months, just to see what kind of issues you might have, what are your successes, what are your questions, how IHS can directly facilitate answering some of those. But I love that idea. I think we do have some resources that we could help with. I think you all have some really good ideas and how we can work more closely with those folks living in urban Indian centers. And I'm wondering, I don't want to be the person asking questions, but I do have a few other questions that like how some of your urban Indian organizations do care for or refer people who are either living with HIV, or how you talk about testing and how you talk about reducing stigma. And those are some of the things that I think I could help you with at IHS. So I'll follow up through NCUIH, and we'll reach out and coordinate an IHS meeting specifically for urban Indian organizations. Great stuff. Thank you.
Yeah, thanks, Rick. I just follow up real quick since you asked a question, which I'll sort of try to answer, though I know there's others on the ground on this call who are better placed. One thing that I've seen personally at a UIO that I volunteered at that was very effective was talking circles for HIV patients. And I know there's significant interest in increasing availability for traditional healing, traditional medicine, including talking circles, but other practices as well for HIV patients. So if there's any way for IHS to support greater provision of those services specifically at UIOs, there's definitely interest among UIOs and NCUIH, obviously.
Excellent. Thank you. And I'm always looking for ways to get more funding, and including for urban Indian organizations.
Fantastic. Yeah, thank you for those insights there, Rick. I do have a comment in the chat from Angel asking what anti-stigma initiatives, if any, are being rolled out across Indian country. Yay,
thanks, Angel. I appreciate that. So we work closely with our tribal partners at the Northwest Portland Area Indian Health Board and the folks at hiv.gov. So we're doing some online campaigns to talk about stigma. One specific example is if any of you use Good Health TV in your waiting rooms, we've got some videos that should be circulating through Good Health TV to specifically talk about stigma and how we reduce it and why people should talk more about HIV. I'm in the midst of working with a couple of folks who are Native living with HIV who want to kind of tell their story, what it's like living with HIV. Specifically, if you ever hear of a woman named Lisa Tiger, and Lisa's a Native from Oklahoma, been living with HIV, gosh, I think going on nearly 30 years. And she used to run the circuit, literally. She's a runner. She would run the circuit around Indian country, telling her story of what it's like to be a woman, be a mom, living with HIV. But we did a video of her, and I'm going to pop that in the chat room here in a minute. So we're trying to do things like that, where we're getting people to tell their story so people can see them, hear them, understand what it's like as a Native person to live with HIV, and hopefully that reduces the stigma. But we're also working to just get people to talk about HIV testing and STI testing and talking about pre-exposure prophylaxis. So we're got a lot of campaigns developed. If you go to We Are Native, I'm going to drop that in the text box here too. You'll find some stuff, and you'll also, I'm going to put the video in there. But that's just a quick little example of what we're doing. But I encourage you to go to ihs.gov as well and look up some of our resources, ihs.gov, and search HIV/AIDS.
Thank you for that information. I asked that because, you know, at our last powwow, we host one of the largest Two-Spirit powwows in the nation. And in our last powwow, we almost reached 4,000 folks joining us for the powwow. And we have pretty broad connections across Indian country, not only in the US, but also in Canada, and we're reaching down south as well. So I know that you know, we're partnering locally with the Native American Health Center in Oakland and San Francisco. But I think that we should be in conversations with y'all to get any and all of these campaigns out, because we have a very strong following, you know, and can reach not only urban indigenous communities, but also a lot of rural.
And I've been to your powwow, and it was one of the most spectacular, amazing, wonderful experiences. It was in 2020, just before we all had to stay home because of the pandemic. But my goodness, that was incredible. Thank you for all that hard work. And I will keep dropping resources in and keep looking back for ideas on what else we might add on to our list of resources. Thank you.
Good afternoon. My name is Meredith Ramondi. I'm the Vice President of Policy and Communications, and I just wanted to invite all of our UIOs who are on here today, if you would like to come off video, and we have the questions attached to the event invite for you all to ask. But we'll give everyone a moment. If you will please come off video, UIO leaders, to engage. We would love to see your faces today. We have maybe Ryan is on here and Daniela, as well as Angel. Ryan, if there's anything related to the programming you all are doing that you'd like to discuss or share with Rick, we'd love to hear it.
Hi, Rick. This is Ryan Ward from the Urban Indian Center in Salt Lake City. I don't have anything specific. I guess no specific questions. But you know, I guess coming from our organization, we're kind of a growing limited healthcare organization, and so thinking about just our patients and those with HIV, syphilis, and, you know, other health conditions, it's a concern. And I think my only comment would be that, you know, funding is needed to support the, you know, healthcare of those patients in urban areas like Salt Lake and other areas. So yeah, I'd love to talk more and kind of look at ways we could partner and make, you know, limited resources stretch. So yeah, thank you.
All very good points. Happy to do that.
Thank you, Ryan. Really appreciate you being here and being willing to share today.
Yes, thank you. We do have another question in the chat from Evie asking, as far as accurate HIV data collections for AIANs, how will IHS ensure that ITU providers included in data collection are included in the data collection effort, I believe, and what current efforts are occurring there?
That's always a good question. So one thing to remember, as I explained earlier, most states, counties, municipalities are required to submit HIV diagnoses to their state vital records office and then up through the Centers for Disease Control. So in a way, a lot of that data isn't just IHS data. IHS has to report it to the state, but if an American Indian goes to say a clinic in Denver, that clinic in Denver, whether it's native or not, has to report that up through the state, and then the state gets it to CDC. So we're pretty confident that as long as people are recording race and ethnicity on those intake forms, we know that doesn't happen all the time, of course, but you can be confident that if someone tests positive in an ITU facility, most likely they're going to be coded correctly, and that information must go to that state health department, and that information has to go to CDC. So that's one part of data that we're pretty confident on is pretty accurate. What we think is not so accurate is people who are in care. So when we're looking deeper into solving this riddle of how do we end the epidemic, how do we reduce by 90% new cases of HIV among American Indians, we're missing probably how many people are getting into care. I might test positive at my tribal health clinic, and that information goes to the state. But if I got into care, where does that data go? That's probably tribal data. Or if I'm seeking care at a federally operated IHS facility or an UIO, that data belongs to them, and nobody has access to that data. So what I'm trying to figure out is how we can work, for example, with our tribal epicenters, with your own clinics, how to teach you how to run your own data. You don't owe that data to anybody. If you've got people in care, if you've got people who are taking PrEP, you've got people who are seeking mental health, substance use services, plus living with HIV, that's your data. No one can ask for it. You don't owe it to anybody. But how do we empower you and enable your capacity to better understand your own data so that you can compare it to some national data? What we think is a lot of really good data exists within the Ryan White Care Program. We're finding, especially with urban programs, that they make a lot of the referrals for American Indian and Alaska Native folks to the Ryan White Care Program. They have an incredibly rich database. So we're making data use agreements with them so we can get annual reports, maybe more frequently, on what it's like for American Indians, Alaska Natives living with HIV, seeking Ryan White care. How many are staying in care? How many get to that undetectable viral load? How many are getting referred for assistance with food, assistance with housing, substance use disorder? So we're thinking that Ryan White care data is a pretty good indicator of what's really happening around Indian country. If you have some magic answers around how we ensure all ITU providers include data, are included in the data collection effort, I'd love to hear it. It's a difficult road, but we're trying to get better and trying to use proxies to estimate what's really happening in Indian country. But we keep trying.
And we do have a follow-up to that question in the chat. As a follow-up, how is IHS addressing the lack of testing and inaccurate HIV incidence data from 2020 to 2022 due to COVID-19 shutdowns?
That's really good. So we probably can't do anything because those years are gone, right? People weren't readily coming in anywhere in the country for a lot of HIV testing. So we're addressing it as we talk about it, we see those blips in the data, and we are just making assumptions that those could be due to people not coming in for testing in that 2-year period. And CDC is doing the same thing. In fact, some CDC statisticians say, we really have to take those 2 years of data with extreme caution, and we can't put a lot of emphasis on what we think those years might say. What we do, and we've always done with Indian Health Service, because we have small numbers anyway, as we look at big stretches of data, maybe 6 years worth of data, and take an average, because we'll see those big blips in data sometimes, and we can't really draw a lot of conclusions. So we're addressing that by looking at years of data instead of just 1 or 2 years.
These have been excellent questions so far. Again, feel free to come off of mute. Feel free to turn your video on and engage in this conversation. I did post that list of topics previously. We've talked about addressing racial misclassification and the effects of COVID-19. These are some of those topics that have been indicated is really important in this topic area. So please feel free, any thoughts or additions that you'd like to add here. And we do have another comment from Evie, who says, IHS itself has officially recognized traditional medicine as an integral piece of health and healing for Native people. How does IHS support traditional medicine in the context of HIV prevention and treatment?
Excellent. We are always promoting that. In fact, I'm going to drop in the chat now a strategy that we developed. We're calling, was that the right one? Nope, I already dropped that one in. Hold on one second. I gotta grab that other. That was the video I dropped in twice. Let me get this one. So we worked really hard over the last couple of years with some funding from the Minority HIV/AIDS Fund to develop what we're nicknaming the IndigiHOS. It's a indigenous strategy to address the epidemics of HIV, hepatitis C, and STIs. And an integral part of that was the indigenous ways of knowing, tribal sovereignty, the use of traditional medicine, the ways that Native people have always come together to address holistic ways of well-being. Specifically, we call out and support IHS facilities to bring on board traditional healers, to pay them at a scale that's commensurate with the cost of living and commensurate with other health professionals. And we're promoting that they participate in training so that not only are they well-versed and capable healers, we also, I'm hoping that we can get them that information they might need to know around the HIV transmission, around how stigma affects people. They're very well-versed in trauma-informed care, of course, but get them to understand the ways that trauma can affect a person living with HIV at the physiological, biological level. We can learn a lot from our traditional healers. We hope that we can teach them a bit about the biology and physiology of HIV and compounding factors like homelessness and hunger and depression. So we purposely call out the need for IHS facilities to employ traditional healers. So great question. We really support that, and it doesn't go unnoticed. And we're working very hard to make sure that our IHS facilities at least can make referrals. If maybe there's a tribe next door or close by, that referrals are made for traditional healing. If you get a chance, take a look at that strategy. There's a lot of good pieces in there. It went around the country for about 1.5 years in Indian country with representatives from including urbans. And we really worked hard to make sure that was a useful document. And we're finding that folks are actually using it. It makes my heart feel good to know that hard work over the last 2 years is having some benefits and people are using it and planning programs around it. So I'm happy to talk about it more in a different meeting, or happy to hear your thoughts about it.
Thanks so much for that, Rick. And so sorry for dropping off like that. My whole system decided to crash on me. So I missed a lot of important things, but happy to report afterwards. But I see another comment in the chat from Dr. Fowler. And so there's a need to care for the entire family after diagnosis. So I'm wondering if there are any mental health supports provided by UIOs for their HIV patients. And for IHS, what is IHS doing or planning to address co-occurring diagnoses when living with HIV?
Great. I'll let the UIOs go first.
Yeah. And I see that Carrie jumped onto the line. So would you like to start us off with that?
Good to see you, Carrie.
Sure, good to see you too. I was just thinking that many years ago when Scott Gyerson and Frank Canizal, don't know how to pronounce his last name, but there was actually a listening tour that they did with UIOs, tribes, and traditional leaders around HIV. So I'm glad we're talking about this again. we do have supports available. I don't know if anybody's talked about data yet, but I think one of the things that challenges us here in Baltimore, especially, is that we know our relatives who are living with HIV and the families that they're in. At one point in time, Baltimore City Health Department said that there were no HIV patients within Baltimore, and so one of our community members was joking with me, like, well, I guess I'm dead, I don't exist. So, you know, I think when we know community members that maybe aren't engaged with our UIO, but are showing that they're testing positive or in treatment, we can also do outreach to them, or you know, work with the systems in place to make sure that testing facilities or HIV treatment providers know that there are UIOs available. And then if they are working with a patient that registers as American Indian Alaska Native, they can make that warm handoff with us, so we ensure that they have culturally grounded wraparound services to really meet their needs. And, you know, we know that we function as Tioshpae in most parts, so like extended family, that we are providing care to everyone who's living with the patient, and then also assessing risk for people who, you know, may need PrEP and other types of services. So sorry, I jumped in, hit the ground running on all that, and that probably sounded like word salad, so sorry.
Love it. Thanks, Carrie.
No, that was great. Thank you so much. Yeah, and I wanted to kind of circle back to you as well, because I know you had some questions on data, and we did cover that, but I wanted to get your thoughts on it as well, Carrie. So please feel free to continue.
Sure. I mean, I think something that has been frustrating, and it's not just Native American Lifelines. I've talked with Abigail Echohawk and you know, the other folks who are related or who are involved with the National Minority AIDS Council, Indigenous CAP, that like in Baltimore City, for example, you can indicate that you're white, Black, Asian, Latino, or other. So statistically, our community members are being othered. And we, you know, because I'm old and have participated in the first like National Native HIV/AIDS Awareness Day, and it's something we've continued ever since, we kind of use that pain point to talk with Baltimore City Health Department and the state of Maryland to figure out how we're going to address it. And that's kind of really a tale of two cities almost. Baltimore City Health Department at the time had a Ryan White bureau chief who really heard what our community members were saying. He often credits Elton Naswood, who most of us know, as really opening his eyes to understanding that when we are not counted, we feel we do not count. And so this gentleman instructed the people who were doing the testing and counseling to not only add going forward American Indian Alaska Native as a box that they could tick, but also ask people to collect information on tribal affiliation. The other side of that is the state of Maryland. When I asked them to unpack the data for Native people, their epidemiologist said your numbers are too small and you don't count. Luckily, Dr. Chalk from the health department was there and stood up, and you know, he had the gravitas to say, oh yes, they do count and we need to do a better job. So I think, and I mentioned this in another meeting, if IHS is telling me as a program head that I have to account for data in a certain way because I'm receiving money, I don't understand why other jurisdictions, you know, aren't told, hey, if you're going to get Ryan White money, you absolutely must collect data in this way and report back on it. So maybe that's naive, but I am frustrated. I've been in my role at Lifelines since 2015. And since 2015, this issue still hasn't been resolved. And what it means is that if I'm applying for grants or wanting to talk about the HIV, you know, impact on our community, I don't have the numbers outside of the ones that I collect, and data is dollars, and that means no dollars will come to us. But it also means that we're not getting interventions where they need to be. So, you know, data is really important, and everybody on this call knows this. I just feel very frustrated that we all understand the importance of data, and yet there still is no fire to make sure that data for our people is collected in an accurate and consistent way.
Well said, Carrie. And I get that frustration, and I felt it for many, many years as well. And I'm inside of IHS, and we have trouble getting data. So you're not alone. Believe me, I can't just walk down the hall or even virtually go down the hall and get data. It's difficult. Our systems are probably old. They're probably difficult to get information out of. We have to deal with privacy. So I was saying earlier before you joined the call, I really advocate for the best way to get data is to go to cdc.gov, because everyone who goes into any facility in most any state and has an HIV positive test, that number has to get reported up through the state to the Centers for Disease Control, who then every other year puts out a new data report. Puts out a data report every year, but the data is about a year old. So I should say it that way. So you know what? That's what we do at IHS headquarters with my national HIV program. We use CDC data. There's a really amazing dashboard using a variety of data. It's called AHEAD, and there it is in the link. And I would encourage folks to go there and just try to figure it out. It's pretty simple, but you can look at cities, I think sometimes counties, sometimes are usually always a state, but then you can look by ethnic group and get some data on what's going on with HIV. It's the best we can do. I think that it's difficult for people to access data. It's difficult for people to make projections. It's difficult for people to have data that makes their case for asking for funds and resources. But I think using what you just said out loud, Carrie, in a paragraph probably will earn a lot of points as you struggle with data. But we're here to help. We use the CDC data. I have the same struggles that everybody else has, but I was talking about how I want to figure out how we can empower tribes, urbans, IHS facilities to use their own data to make their own case, not show it to anybody. You don't owe your data to anybody. It's yours. It's you. It's private stuff. It's secret, sacred information about your relatives. But maybe what we can work on in the future is helping you analyze your own data to make your case. But in the meantime, check out AHEAD. Call me up. We'll help you look at some data that's representative, at least representative of urban Indians in the Northeast, if it's not specifically Baltimore City. But I think there's ways in the meantime, while we're looking for an answer to all this craziness, that we can help.
Thanks so much, Rick. That's a great resource. And I'm so glad that we were able to provide that here. Wanted to circle back to the traditional healing portion, unless there's anything else, Carrie, that because I don't want to cut you off if you had anything else that you wanted to bring up.
No, and I don't want to like bogart the whole thing, but I also just want to say, Rick, I for many years have really appreciated the way that you've led on this and that you've stood for our relatives. And I also want to honor the late Adrian Dominguez, who was at UIHI, who came and really advocated for us here in Baltimore when he didn't have to do that. So I'm glad that there are so many folks out there fighting for our urban relatives to make sure that attention gets where it needs to be.
Thank you. Thank you.
Thanks so much, Carrie. I'm going to go back to the chat and follow up the question that Evie had about traditional healing. So does IHS, have plans to work with CMS to expand reimbursement for traditional services provision to Medicaid beneficiaries seeking treatment or testing for HIV/AIDS at UIOs? And if anybody has any thoughts on that as well from the UIO side, please feel free to jump in. All right, goes back to you, Rick.
Okay, so I don't do a lot with CMS. I have in the past. Well, I'm saying that I'm typing. I put the wrong link. I keep copying and forgetting to recopy the new link. So I want to give you a link for the Project Echo, but I'll do that in a second. But I think it's really important that we work with CMS, but that's I think a little beyond my purview. I think that would be best from UIOs or tribal entities who have a lot more power than I do from one Fed to the next. We support it. I've definitely talked to CMS about it. But I am happy to keep talking about it, but I really think that that power lies in community leaders from our relatives.
Yes, thank you so much. Are there any other thoughts from our UIOs in the room?
I see we have a hand from Candace.
Yeah, I just wanted to share a little bit of information from my role as technical advisor to the CMS Tribal Technical Advisory Group. There are 4 what are called 1115 demonstration projects that are currently being considered by CMS to expand reimbursement for traditional healing throughout the ITU system, with some varying degree across those 4 states, the extent to which that will potentially be offered. So they are Washington, Oregon, California, and Arizona. And I would highly encourage any UIO leaders who are on the call to engage with your state Medicaid offices regarding those 1115 demonstration projects. And if you're in a state that doesn't have one of those, I would encourage you to talk with the tribes in your state and sort of from a unified position, engage with the state Medicaid office to talk about your state submitting one of those 1115 demonstrations. They're a little tricky to do, and it does require some work by the state. But if the tribes and UIOs come to the state through consultation and confer and really push the state hard on expanding those programs, some states have shown interest in doing that and expanding access to traditional healing for Native Medicaid beneficiaries in that program specifically. So I'm happy to answer any more questions that you may have about that process directly. If you want to just email me, I'll drop my email in the chat, and happy to talk about that more with anybody who's interested.
Thanks so much, Candace, for providing that information. Yeah. Any other questions or comments about the CMS portion? Thank you, Candace. Awesome. We have a couple more minutes left in our open floor. So if you have any more things that you would like to present here at the session, please feel free to come up with mute and get on camera as well. We would love to see your faces.
Vivi, if we got a minute, I just wanted to, that last link I dropped in about Indian ECHO. So if you folks don't know what ECHO is, Extensions for Community Health Outcomes, originally started by University of New Mexico. But we are doing an incredible job with our partners at the Northwest Portland area Indian Health Board, again, funded through the Minority HIV/AIDS Fund, to do this national work on just about any kind of disease entity you can think of. So I encourage you to look at their site. That link will take you directly to a program that's happening tomorrow around HIV. But we do grand rounds, so we'd be ecstatic if we came up with a UIO specific programs, some of your providers or health educators or administrators, to look at how we can focus in on some of the issues you're dealing with HIV care and prevention. This one tomorrow is specifically around PrEP. We really want to see how we can help UIOs gear up and start offering PrEP. We're also, so you might have heard about pre-exposure prophylaxis for HIV prevention. CDC is getting ready by the end of September to release policies around PrEP, taking doxycycline to prevent various STIs. So IHS is going to follow suit. We've got our stuff all ready. So we'd like to give you a little heads up that we're going to start recommending that people have access to doxycycline post-exposure, which studies are showing really reduces greatly the chance of acquiring an STI. But anyway, Project ECHO, good stuff. Check it out. Check out the whole set. You might be surprised at how many incredible opportunities there are for learning.
Yeah, and we have one final question. Thank you so much for plugging that, Rick, because I really enjoy all the ECHO sessions that I've attended. So yeah, And Angel has a question. Any updates on any national actions or initiatives around the current syphilis uptick? So syphilis, yeah.
Oh my gosh, thank you, Angel. That is really what we're focusing on so heavily right now. We've seen like up to a 900% increase in some of our native communities in syphilis. Very, very sadly, we're seeing congenital syphilises that are cases that are leading to fetal and infant deaths. Most of it we're seeing in communities where injection drug use or other substance use is high. We're seeing that a lot of pregnant people are not getting into prenatal care, so they're not getting those 3 touch points for syphilis screening at pregnancy diagnosis, midterm, and then at delivery. A lot of folks show up to deliver at emergency departments. Sometimes it's too late. So our recommendations are people should be able to walk into any clinic and get an on-demand syphilis screening. They shouldn't have to make an appointment. They shouldn't have to talk to anybody about anything except, can you please test me for syphilis? Soon we're going to have syphilis test kits available for free via mail. That's coming soon through our partners there at Johns Hopkins. So shout out to Carrie and your Baltimore people. But we want to make sure that people talk about it. We want providers and the community to talk about how important it is to learn about syphilis, teacher practitioners what syphilis looks like. A lot of people went through medical school and never saw a case of syphilis. It's something that's rebounded and people don't know what to look for, especially latent syphilis. So go back to Project Echo, that link I sent you, and enroll in one of their syphilis echoes. Learn about it, promote testing, get people into care. One of the things we're finding is that IHS has a federal rule that prohibits us from texting people to get them in for their case management reminders. So we're trying to work around how can we get case managers trained in urban Indian organizations and tribal settings that could take over case management. Simple things like just reminding people, hey, Rick, don't forget you've got an appointment at 2 o'clock on Thursday. That's all. I'm not going to say, hey, you got syphilis, come back in. It's just like, all we want to do is say, come in for your appointment. A lot of the folks maybe living couch surfing, maybe living in a park, so they don't have like mailing addresses. So we're missing them, and we're missing an incredible opportunity to get people back in for basically, it's if your initial stages of syphilis, 1 shot of penicillin. Latent syphilis might require 2. So we got to get those people back in. We got to make sure we get a hold of pregnant people to get them into care to prevent congenital syphilis. So please keep thinking about it, talk about it a lot, and then go to Project Echo there to learn about how you can, as a UIO in your clinics, can really learn about treating, catching, and trying to get a strong foothold against the spread of syphilis.
Thanks so much for that, Rick. And I think that's where we're going to wrap up on syphilis, another comorbidity with HIV, obviously. So we're going to wrap up there. But thank you so much, everyone, Rick and our UIOs and all of our other attendees for participating in this year's HIV/AIDS listening session, Harvesting Hope, Strengthening HIV Services in Urban Indian Communities. We truly, truly appreciate your presence, all of your comments, your questions, your insights during today's session. Next slide, please. And with that, we would love, love, love for you to give us any feedback that you would like to about today's session. You can complete the session survey using the QR code on this by scanning it with your phone, or you can click the link that Margot has placed in the chat here. And remember, you will have a chance to receive exclusive NCUIH swag package if you fill out this link, a chance to do so. We do have some upcoming events on the next slide that we want to go through. Our 2023-2024 Emerging Leaders Council application is open till the 31st. So if you would like to plug this to your youth, please, please, please do so. On the 29th, we're going to highlight also the STI Groups event, which is enhancing culturally responsive sexual health communication in urban Indian care settings. And so if you want to look at all of these different events, please visit the NCUIH.org events page for more information, registration links. We also have the save the date for our upcoming HIV/AIDS resource toolkit. So please take a look at that before this office hour session that comes up in September. We really love your inputs on this, this toolkit. Want to get your thoughts on what we can improve upon, or what we can add to it. in that sense. And we also have the assessment from our STI team as well that is still open. We're looking for completion of that as well. So if you're interested, and we're going to drop the link to that in the chat as well. But yeah, feel free to pop off. Have a wonderful rest of your day. Thank you again, Rick. It was so wonderful to have you here, and just have a wonderful rest of your day. Thank you so much.